So before coming here, I'd obviously read up on this, but I think it's become slightly clearer to me that we are in reality talking about a continuum of quite different situations, where on the one side you have large cohorts which you might want to establish whether or not you're doing tricks. Cohorts that have other functions, studying the natural progression of the disease or something else, and you embed tricks within that cohort. And on the other end of the continuum, on the other extreme, you have cohorts which essentially are set up primarily to be recruitment vehicles for tricks studies or similar designs. And I have to think more about it, but I think that the ethics, sort of how we have to think about the ethics, might play out differently in those, because in the large cohorts, if you are a participant, you are participating to science in a very real way, because these are, even if you never get into either the control arm or the intervention arm of any trial, you're still participating, or adding something to science. Whereas it's not as clear to me that sort of the unfortunate person in a cohort which is set up primarily as a recruitment vehicle, who is never actually used for anything, is contributing to anything. So that was my observation.
Would you like to comment on that?
So it seems to me that what you're talking about is the intention behind setting up the cohort.
Or how it functions.
Okay,
so you could
let me
intend
just
something
follow
and
that
it
up.
could turn out to be...
Right. So if you produce and commit to producing a report on the outcomes of usual care, which is what the cohort is set up to do, that is precisely the same as a cohort that is set up only for that purpose. So if you do that, you have created and run a full effective cohort. If you, in addition, add to that value by doing a randomized trial within it, I think that's got to be better than a usual cohort, not worse.
No, that's precisely my point.
Right.
But
Well,
that cohort has value whether you ever do a tricks and everyone in...
Right, but what I think we're at risk of is saying that because there is the possibility of randomized trials inserted into the cohort, the actual promise to do a cohort study is irrelevant, and therefore it has to be judged as a traditional randomized trial. No, I don't think you're saying that, but I think that's how it could easily be interpreted, and I think that is, this is a way of restricting science.
I think it also points just to design considerations that are good to keep in mind, rather than being a real problem with Twix itself. Like Linda, I think your experience is a good example, where you guys could have designed your cohort in such a way that you would enroll people who consented to observation but not to trials, and you said, why would we even bother to do that? And that's, I think, a way of those kinds of design considerations, if they're all taken seriously, I think would address your concern.
Which, by the way, doesn't mean that we're not using the observational data
Yes,
as well.
sure.
So we are actually using that too.
But I think it's a bold statement from your group to actually say, for us, the interventions are the most important part, so we only want eligible people for interventions. And the other ones we exclude, so I think that's a very bold and important ethical statement as well.
Does anyone involved in surgery here at all? Yeah. I mean, when you go to a surgery conference, basically every talk will go like this, or a whole series of talks, subcategories will go. I always used to use cautery at the bladder neck. And then I thought, what about, that might cause damage to the blood vessels, so I went athermal. So, January of 2014, I started going athermal. Anyway, here are my results. And that is just routine, or I'm running into one of my colleagues and he said, I really should look at the data because I just stopped using the drain. I thought, why are we using the drain? So anyway, I stopped using the drain, so I should probably have mine. And that is just absolute every day. work that is in surgery and is in every OR that you'll ever go into and in every surgical conference that you ever go into. And I always find myself sometimes confused that we're splitting these ethical hairs over research because we say we want to do it up front. We say we're going to do it, where all these surgeons aren't telling anyone that they're going to do it, and they just get on and do it the whole time, and it's just seen as a part of being a good surgeon, right? A surgeon who didn't try and develop his or her technique to improve their outcome would actually be seen as failing in a professional duty.
But there's an explanation for that. It's because the relationship between the surgeon and their patient is fiduciary. There's an entire legal, theoretical framework around that relationship in which the surgeon is obligated to do the best by their patient. When you bring in the researcher-patient relationship, there's no necessary fiduciary relationship. And so a whole different set of ethics apply, which originated after the war.
Wait a minute, I'm in a hospital.
Yeah.
And
No, you have no patients.
But I have actually a responsibility to make sure the patients in my hospital do well.
In general, but
you
not
know.
individually.
Oh, I think, okay, whatever legally
No, I
is,
think
there's
I think
quite
this is really
clear-
serious.
No, I think there's a quite
I
clear
think this-
ethical responsibility.
Somebody
as
pointed
well.
out the difference between when you're in the law. Oh yes, it was you. So when you're in the law or when you're in the ethical reasoning, and I think law is a framework that isn't tightly tied to the underlying ethical reasoning.
Yeah, I'm
But-
agreeing with you. I'm saying
Yeah.
that, but
It's wrong.
maybe I don't have any legal. But I mean, I think every single member of
Yeah.
the staff at MSKCC
Absolutely.
has this strong ethical thing to make every single patient's
I think that's
experience better. So I'm not quite sure
But-
exactly what the difference
But
is.
UK surgeons do it in that way as well, and they do not in law have a fiduciary duty, very explicitly stated that they don't in a Supreme Court judgment.
Wait, what?
But
Sorry,
they do not, no UK doctor has a fiduciary duty to a patient.
What is their duty to their patients?
They have a duty of care,
Huh.
but, well, there are lots of legal niceties here.
Okay. Sounds like it might. Anyway,
Yeah.
sorry.
Yes. You have to take it up with Lord Scarman and his debt.
Sounds good.
Now, my claim would be that these are not good surgeons. They're all bad surgeons because they should do proper controlled trials or at least properly designed experiments.
Right. And then there's a naturalistic objection to that, which is therefore pretty much every academic surgeon is a bad surgeon.
Yes, correct.
And if you're going to make that, and to me that's a prima facie ridiculous claim. Right? And if every single surgeon that is very widely respected and followed them and made huge changes. I mean, the radical prostatectomy, people are not incompetent. You know, they used to be impotent, 100% impotence rate. Why is that? Because somebody said, oh, look, maybe we can spare the nerves by doing that. You know, that's a randomized trial.
How about they're not bad surgeons, but they're failing to capitalize on the best that they could do by failing to organize their care in a scientific way.
I'm
Right,
happy
but
to
why
say-
do they do that? Is because the ethical is so difficult to get into
Exactly.
ethical committees.
Exactly.
No, but
No,
things are
but
changing.
it's really-
Things-
yeah.
And do you know the ideal recommendations?
yeah.
So
Yeah,
things
that's-
are changing. It's
it
no
is
longer
moving.
acceptable.
Moving.
Yeah, so they still, you can still try, I mean, to
Yeah.
do differently, but after that, after you have shown sort of proof of concept, then it is, I think, it's sort of accepted more and more that you do things with ethical approval in an organized way. And also within the ideal framework, Twix is one of the designs that's
Best
being
to use, yeah.
advocated.
Because it always starts with it usually starts with an idea that comes from a situation you weren't expecting. When I'm suturing up a patient and the wound doesn't close, all of a sudden I change my technique and I start to do it differently because at that moment I need to close the wound for that patient. But then as soon as I start to think that there is that it would make sense for more patients, that's when I go to Lenny and I say, hey, this is what I've been doing. Let's start systematically evaluating this. But of course it always starts with some acute situations where you have to deal with certain things. So there's a gray area. When do you reach the point where you start saying we need to evaluate this systematically, and when do I just do it from my gut feeling as a doctor to provide the best care that I can for this patient?
But there's some very good and very recent evidence that we have to do much more systematic evaluation in surgery. surgeons have been putting scopes into all kinds of joints, doing all kinds of things. And most of the research coming out now shows that it has absolutely no effect except on the surgeon's bills.
No, I'm
And then
all
we'll
for
argue
it,
about
but I'm
learning
just saying
curves.
that, you know, if you...
There's the learning curve as well,
Yeah,
where
yeah.
they will say we can't do it until we've learned the technique, and at which point is the tipping point
Exactly.
when you could do
Yeah.
the randomised control trial. Baselines aren't used, there are no independent outcomes measured, and it's a battle to get surgeons to even do that.
So,
Go ahead.
okay. Now, I was just trying to bring this back to.
To the initial question.
Yeah. I know there's a connection, but I want
the
somebody to
connection
remind us.
was
Yeah.
exactly what. Sorry, maybe you missed that. Is
Yes.
we're worrying so much, and adding all this extra. Why aren't the surgeons doing their studies? Is because it's so difficult to get the trials done, right? Now, Claire's come up with an idea which would make it very easy to do these sorts of trials. These trials aren't going to be done within a good enough ethical framework. If we try and make it so difficult trying to get the perfect ethical framework, it won't be done at all because there'll be, you know, I'm not expressing myself very well. But if we can get an ethical framework that is sufficient, then maybe surgeons would start doing their trials. The current way in which it's done, it's too burdensome, and they don't do those trials at all. They just
Well,
don't.
I mean, there are multiple reasons why it's so hard to do surgical trials. And I think, it seems to me that's a whole another universe of discussion because it's so difficult. I mean, we could talk about it if you would, but I'm just trying to bring it back to cohorts and, you know, whatever.
So to bring it back to the cohorts, what is the next comment you would like to address, or would like to see addressed at this point?
I just wanted to piggyback on what you just said about how important it seems that you have to look at individual studies, because our ethical intuitions about what might be appropriate and not, even with the pre-randomization broad consent content issue, it seems like that would vary depending on the study as well. So, I think that it's been really, really useful to hear all these different perspectives. So I have some broad ideas, but it seems like we still need to think about some of these conclusions as kind of tentative, and we have to really think through to see if we can make broad statements about, yes, you can do that, yes, you can't, because until you look at the particulars of the trial, I would have some difficulty. So that's one of the things I've sort of learned.
But it might be useful to at least make concrete statements about what's conceivable.
Yes.
Because I think we have some impressive examples here
Yes.
of trials with rather minimal consent that seem very
Because
ethical.
I think there are a finite number of these considerations. You know, what's a major intervention, right?
Yeah.
And how broad is the broad consent at the outset? Nature of the cohort. How general is the cohort? Is it very disease defined versus pretty general population cohort? So we might be able to start enumerating some of those things as a checklist that you have to go through when you do the case-by-case analysis.
I was a bit, well, worried, maybe a big word, but a bit worried about, I think it was your talk on tweaks for drug trials, where there is some kind of rule that also controls in a drug trial need to know that they are in a drug trial. So do you think that tweaks are in for that reason? I mean, yeah, looking at tweaks as the control arm is not told about being a control, the tweaks are not feasible for drug.
I raise it as a legal question that would need to be addressed. I can't issue a definitive statement on whether a participant in a trial, even though they are in the control cohort arm, would need to be given all the information about the interventional arm of the trial as well. I just raise it as a potential difficulty that needs to be addressed in terms of whether those types of trials will satisfy the UK clinical trials regulations, because there's an argument that they may not, but there may also be an interpretation that they do. And I just raise it as one of those issues that needs to be addressed before large-scale drugs trials
Are
are on the
there,
table.
Claire, do you know, are there any twig drugs?
Well, yes, I mean, they are taking place.
But doesn't it depend on whether we're talking about unlicensed or licensed treatments? I think as well.
Okay,
So,
There's a burning question in the middle.
and the impression we got from Kirsty yesterday was that it would be feasible. But I think it does need a bit more exploration.
I don't know the drug to put it. You wouldn't have necessarily a clear control group. So in the drug trial, it might be, antibiotic A versus B or 2 comparable statins. So it's not quite clear what the control group would be.
Well, there's a lot of diabetes trials that are add a drug versus usual care.
Question, and I think Harry's starting to lose.
So I got funding last week for £1.1 million for an NIHR.
Oh wait, actually, we don't know what it's for yet.
NIHR funded CTIMP Twix.
Now we go.
I'm seriously hoping it gets through MHRA. So it's a medicinal trial Twix. So it's that poster there with the yellow and blue stripes. So it's a disease-specific cohort. It's in psoriatic arthritis. We are interested in the cohort as its own thing. So the cohorts are getting new European guidance standard care treatment, which actually most people don't get. So it's kind of above average, but it's within what's considered standard of care. That's not an IMP, that's not a CTIMP bid. But then we're looking at other drug orders within the trial design, hopefully. And so our plan was kind of to do an Utrecht kind of stage consent and to get consent for them, to be randomised, to be selected, all of that kind of thing, with the understanding some of them could just be cohort as well, if they chose that. But now I think the big issue for me is going to be whether we have to tell the control group. So the trial that I did before this, which is where the European recommendations came from, was looking at treat to target, so measuring a particular target at every visit and adjusting therapy to hit that, versus standard care, and that was a traditional RCT, and we had major disappointment bias problems in our standard care group. A lot of them were very hacked off, because some of them were even travelling a lot further to come to our centre to get into the trial, and then they got standard care. And actually we didn't have awful dropouts, we managed to persuade most of them to stay, but because of that I wanted to do this as a Twix, and if I now have to tell my cohort once they're selected that they're controls and that they lost the lottery, then it's going to take out some of the point of doing it that way.
It's worth having an open trial, not blinded.
Yeah, so it's an open trial. It's not a trial of a particular drug intervention, so it's the order in which you use the drugs. But our list of IMPs for Tacopa was about 10.
List of what?
Investigational medicinal products. So the list of potential drugs that could be used is quite long. They're all within approved kind of standard care, just used in slightly different orders.
Oh, so they're all approved drugs for the indication of psoriasis.
Some of them are not technically licensed but are routinely used. So our most commonly used drug for psoriatic arthritis isn't licensed for psoriatic arthritis. It's licensed for psoriasis and for rheumatoid, but not for PSA. But they're all routinely used therapies, so it's considered phase 4 by MHRA.
And your control group, the cohort, you said you actually provide a kind of practice algorithm for them as well by being in a cohort.
So the cohort will receive best practice care as per the European treatment recommendations.
Which many of them hadn't gotten until
which I can tell you, so that is, as a result of our trial showing treat to target did better, the European recommendations now say everybody should get that. Nobody does it because they don't think it's feasible. They don't think they have long enough appointments to do the measurements and to escalate the drug. They think it's too much hassle. The compliance in the UK is not great, the compliance in the US is way worse with doing that. So we're actually implementing that as a standard of care, which it should be, but isn't. So the cohort's very interesting because it's the first big group of people who are having that, or being offered it. But with the cohort just getting it as standard of care. So that is what everybody would. I mean, yes, offered. I guess.
They get offered, not received.
They can always say no to anything, obviously.
But it's directed by your protocol. I mean, that's not just standard care and you're piggybacking on the back of that. They will get this standard of care because they are in this trial.
Well, we're implementing the European recommendations, so I would argue that bit isn't a CETO.
They will be getting it because of your protocol. They wouldn't get it any other way.
They're getting it because of the European recommendations.
Well, it's because your protocol is adopting the European recommendations as an arm in your trial.
But there might be another definition, which is they're getting it because the institutions in which you're doing your trial have chosen to implement the European regulation.
But if they have,
but this is
and
the
you run a
framing
trial
issue.
and they get it, they wouldn't have got it unless you were trial.
The idea is that everybody in the centres will receive that as basic standard of care, will receive the treat to target.
No, it is.
But then obviously the interventions are definitely CETO level, because in the interventions we're saying, for the interventional arms it definitely is, the cohort should be.
I don't know, it's not, I'm MHRA.
Okay, so we have one final remark, because Claire was already signaling me. So one final remark from you, and then I would like each of the panel members to give us a take-home message in just 20 to 30 seconds. So you can think about that while you pose your question.
And I wanted to go back to the thing you started with when you spoke just now about the poor person who's not used in a way, the way you sort of phrased it. And I wanted to connect that back to what you were talking about in your presentation earlier. And you were quite pleased to see the sort of connection with the ability to consent and the ability to withdraw. And I think I'd quite like to throw into the mix there that the value of consent at the front end is flagging up the potential for a relationship with research. And we don't sort of think about that as a benefit so much. And one of the studies that I did recently was with bereaved parents whose babies died after being in a neonatal intensive care trial. So those parents had a very, very brief relationship with research, sometimes 24 hours before their babies died. And I was interviewing them 6 to 8 years afterwards. And the way they valued that research was really sort of complex, and we pulled it all apart and we came up with a great diagram about different ways in which their relationship with research is important. So I think that speaks to sort of the front end of your research and how you set up the relationship people have by entering this research and what they're offering. Because what these people felt was that there was an achievement in that, there was something really important, and everybody expected them to actually be really quite angry their babies had died, and it was quite different. But I also think an awful lot of the research that we do is front-loaded. It's looking at the sort of entry into research, and I would really urge you as a sort of room of researchers to think about the back end and think about exploring the research experience across these long cohorts and out the other side, and how people feel at the end, how things are managed if anything goes wrong. Trials sometimes do, if trials stop, if there are any sort of worrying things that happen, how do you deal with that? How do you deal with communicating results in these different methods? And I think because you're at a sort of an early stage with a new methodology, you have that potential to sort of follow it through and think thoroughly about what you're doing.
Thank you for that. I guess it's a nice take-home message as well. So to end this part of the session, before I get back to work to Claire, I would like to start with Scott. Could you give us, could you give us one final remark, something you want the audience to see as a take-home message from your point of view?
Gosh, I just want to thank Claire for inviting me. I've learned so much in these 2 days, and I think, as I said when I gave my talk, I was very intrigued by this design, but it was hard to understand it. Now I think I understand it better. I definitely see just tremendous potential for this design. And in some ways, I mean, the heart of it is kind of it's somewhat revolutionary in the sense of we don't always have to do it the way we've always done just because that's how we do it. So from that angle, I think it's really important. And I've really learned that, that's one. However, I do think that there are so many variations. I mean, we just got to the very tip of the iceberg of your trial and how to think about it. And we just talked about for 4 minutes. And I think that's going to be true for a lot of these. Yet, all the principles that we've been exploring, I think, will help. And I think it's very exciting to have been part of this discussion, and I hope we'll continue to talk.
And I also think now that we have a sense of communities, it's even easier to start, to contact each other and say, hey, can you help me with this and this question that needs to be addressed. So I'll ask the next person for a 20 to 30 second closing remark.
Okay, I think my sort of take-home message would be that there are lots of things we have to do to treat research participants in an ethically acceptable way. And some form of consent is only one of them. And I think in designing new methodologies, our main concern should be, well, how do we treat our new research participants in an ethically acceptable way? And that might not involve informed consent, it might involve many other things. But the thought has to be in our mind, and we shouldn't just, well, in designing methodologies, the technically optimal and the efficient is important, but the research participants are important as well.
So I was enthusiastic about Twix when I got here, and after 2 days of exposure to the ideas, I've gotten steadily more enthusiastic, which is the opposite of my reaction to most things in life. So that's a good sign. Yeah, I mean, I think it's really promising and really has a lot of virtues, some of which are only apparent after you learn more about it. One concrete specific thing that struck me, I think when I came to this conference, I kind of assumed that the part of the rationale about sparing patients distress and disappointment, that was not at all compelling to me when I got here. But as I see more examples, I'm starting to see that as a major virtue of the design.
I suppose the take-home message might be, from an ethics committee perspective, is if you're thinking of doing a Twix design, is to ensure that you're doing it for the right reason, and that you present your justification to the ethics committee for why you're doing a Twix design, not because it's a new sexy way of doing trials and you just like to give it a go, or for any other kind of reasons. There's got to be a defensible reason why you're not using a traditional design, which ethics committees will understand. Why you're using this new type of design, defend it. As James said, I think initially I was kind of not entirely convinced by this kind of saving people the disappointment kind of not being in a trial and disappointment bias, and ethics committees may also share that. There are, as has been pointed out, I think justifiable reasons why that might be persuasive to an ethics committee, but again, you've got to really make that case and come with evidence if you have evidence, and as we've understood, there's not a lot of evidence out there, but just provide the evidence to the committees why you're using this type of design. Oh, and secondly, also be aware of the law. Be aware of the law, because it's your responsibility to comply with it.
Similar things, really. I think there's a lot we can do to start paving the way with the RECs in terms of training and producing guidance and organising sessions with the ethics committees to show them the benefits of this approach. But they do have quite a high level of scepticism, and I think the point that Scott made earlier about cohorts that are set up to do other things vis-a-vis cohorts that might be set up purely to take through a specific TWIC, I think might raise scepticism in the eyes of some RECs in terms of, is that just a backdoor way of not consenting properly half the people in the study? So I think those things need to be considered, and you do need a justification for the approach. But I think we can certainly help with taking this forward, hopefully. There's lots of things we can do to facilitate that. So the other thing is if you want to be involved in helping us develop the survey, please talk to me in time.